All right, well, thanks everyone for joining. We have an exciting session. So this whole session is going to be focused on CT-guided PCI, and a lot of people at first may be wondering why there's a whole session on CT at an interventional conference. And hopefully over the next hour and a half, if this isn't something that's already part of your practice, you're going to see how this, I believe, is the future in changing coronary interventions, and really something that I'm most excited about for coronary interventions. If you think about how structural heart is all about procedural planning and making decisions before you get to the cath lab, that's what this is trying to do and change the field from ad hoc decision making to really coming up with the best solution for our patients. So we have a great panel, some great talks, and we're going to kick off from Yader Sandoval, who's really leading the charge in this whole field in the US. And he's going to talk about a recent roundtable and expert consensus paper that was published. So turn it over to you. Thanks.
Thank you, Evan. Thank you for the introduction, and great to be joined by a great set of panelists. And thank you for CVI for the invitation and opportunity. Do we have the slides up? Oh, perfect. All right, good. So again, as Evan introduced, this is something that some of you might have or might have never heard about. I see Farouc here, who you've been talking about this for you were the original pioneer. You've been talking about this for a while, but I think it's until now that it's really resonating with way more clinicians. And part of the reason is because a lot of things have aligned at the right place at the right time. We have the right hardware, the right software, better technologies, better data, an ongoing pivotal trial. So everything has just converged at the right place at the right time, that this has shifted from something that was a distant futuristic vision to something that now is actionable in your practice tomorrow. And I'm not lying. You can literally, throughout the session, incorporate some of the elements that we'll discuss and bring into your practice tomorrow. I do work with a number of companies in this space, and I'll be showing some of this stuff. The field has, I would say, taken a really huge leap, particularly, I would say, over the past year or two, particularly as it's been recognized that the data and resources available to perform CT-guided PCI are now at a clinical level that now societies have recognized that we need to provide some guidance of how to use these tools. So with a number of people here in the panel and others in the audience that I see, there's been now co-societal partnership from SCAI and SCT to come together and say what's happening now and what's happening in the future. If you say, I'm interested in this, this was co-published in JSCAI and JCCT. It has all the details, references, so look at this, but just be aware that you're gonna be hearing about this more and more and more. What is CT-guided PCI? So CT-guided PCI, the basic definition is that we need to move beyond the report. I think all of us, I trained level 2 in CT, and I really never really captured the idea of we're going to use this for PCI until like 3 years ago. The idea is that we need to move away from a simple report. We need to interact with the data. So either we go downstairs and find the cardiac imager or radiologist and look at the images together, or we learn how to look at this. Manos, I think he was there. Manos and I would run a workshop yesterday for CT-guided PCI, which we met with a lot of fellows, and we just went case after case after case. I think some of you were there. We need to learn how to interact with the information, and that is CT-guided PCI. This is not some novel transformative thought. Any other procedure, I would argue, in cardiology happens this way, right? If you're doing a tricuspid valve, left atrial appendage occluder, whatever it is, aortic procedures, EVARs, if you're having a TAVR, you plan. But for whatever reason in PCI, we have historically say we're going to wing it and figure out in the cath lab. But the reality is that you can use CT to plan your procedures. You may be skeptical and tell me, Charlie, great to see you. You may be skeptical about this and say, do we have data to do this? Maybe there's too much hype and enthusiasm, but I want to point just here at the upfront that there are 3 randomized trials, actually more, suggesting that if we use CT, this can be better for our patients. There's a trial now 4 years ago, 2021, showing that if we use CT for CT or PCI guidance, we improve procedural success and have fewer complications. I recognize that maybe some people here, Lorenzo, maybe some others may not feel that, may not need that, but I would value it. I don't do 200 CT or PCIs per year. So if I can get additional information that can help my procedure and help my patient, that may be of help. there are not one, but two randomized trials in patients with prior bypass that are positive and show a reduction in procedural time and nephropathy. So you can already see that there's different endpoints. There are some people that are interested in outcomes. There are other people that are just interested in making the procedure more efficient. And there was just a pilot trial for osteolesions. I think we all can agree that osteolesions is a tough subset, that there's a trial that was just published on that. I was talking at the beginning of the talk how a number of things have converged. One thing that has really propelled the field is that there's an ongoing pivotal randomized trial. It's called the P4 trial, led by our good friend in Belgium, Carlos Collet. This trial will probably finish enrollment within the next 2 to 4 weeks. Actually, we just enrolled probably our last patient a couple of days ago. They're trying to push us to get a couple more, but it will wrap up within 2 to 4 weeks. And this is randomizing patients to CT versus IBUS-guided PCI, non-inferiority, 12-year MACE, and this will really define how the field moves forward, but be aware that this is one of the major reasons right now there's a lot of interest in this field. Charlie, who just joined us, and I invite all of you to stay until 6 because this field does not happen without Charlie Taylor, who's sitting right there. He was the one who came from FFRCT to getting a dedicated tool for virtual PCI guidance. The reason I'm here right now is because, to be honest, he came back in 2023 to Minneapolis, and he said, we have this new tool that allows you now to do PCI guidance from a CT. Can we learn how to use it? And we started using it. This is a picture of me in the cath lab. We had this on wheels. We looked at the plan. You get the anatomy. You get your optimal angulations. And critically, you understand what is the predicted post-PCI FFRCT after planning this. And this is what got us introduced into the idea of, can we use CT beyond just a diagnostic tool? That evolved over time and evolved from physiology to integrated plaque, calcium, and the whole procedural package. So this is what I like to use now, and this is what we teach our fellows and people that work with us in the field. I like to call it the one-page pre-procedural plan because sometimes it may look too complex. As you can see, you can fit the whole plan in one page. You're like, what's the anatomy? Where are the lesions? Where the course and its calcification? You can get an MIP in the top left. What guides do I need? You can use the axial views. What's the length of the disease and the phenotype of the disease? You can look at multiplanar reformation and cross-sections. You can further characterize calcium, and we'll have a talk on calcium, so I don't want to get ahead of it since we'll talk about calcium in this session, but you can look at calcium characterization, and you can look at CT-based physiology to understand functional, whether is the disease significant from a functional aspect, is it focal or diffuse or mixed, and do virtual stenting. So as you can see in the bottom right, you can get a whole plan checklist before you enter the cath lab, and that's pretty transformative. So again, what propelled now this year to go this to another level is that a number of us here in the audience and on my back came together, people that are leaders in complex PCIs, trialists, registries, guidelines, whatnot, came together and said, can we put this together? And Evan, who is of course sharing this session, was there with us, and we came with some guidance with what are the elements. The elements are the left are basic CT information that we want to use. This is something that we need to educate what the nomenclature is, MIP, maximal intensity projection, axial images, multiplanar reformation, short axis cross-section, to characterize the disease, and on the right, elements of physiology, myocardial mass, and live CT guidance. Why is it important? Why has our practice captured this? I practice in a high-volume private practice that they could say, I don't care about this new academic initiative. The reality is that they saw it totally differently. We told them, we have a diverse cath lab in our healthcare system. We have an ASC, we have a non-surgical backup lab, we have a mothership at Abbott Northwestern that has all the tools, and we have a diversity of operators. We have people like Mano somewhere here, does all the CTOs, and other people that do just a handful of PCIs because they have it structural. So can we use CT to better triage and help our patients? So if we use CT, we can take the case on the left, and anybody can do this at the ASC, at the non-surgical backup lab, any time on the go. Whereas the case on the right, I want Manos to do it at Monday at 8 a.m. with the proper equipment to deal with that. MIP, this is a view that has been increasingly been popularized because it's practical to look at it. The moment you bring this to your radiologist, they will roll their eyes and say, we don't use this, but us interventionals, everybody here, will look at this image and say how in 1 second you can understand that the case on the left is a straightforward PCI, whereas the case on the right is way more complex just from looking at one image. Axial images are important because you can select your guide. The right comes at 11, the left coronary artery system comes at 4. So you can see, you can triage complexity, you can choose the guide. Here's one case that shows the right coming at 1 o'clock. Therefore, you need an AL1 guide. Therefore, you reduce instrumentation, you reduce radiation, you reduce contrast. And these things are tested right now in ongoing prospective studies. Evan here in my back and his group, they have pioneered the concept of MLD for IVUS and OCT. We don't have to reinvent the wheel, therefore let's go ahead and do a CT-based MLD. Is the lesion calcified or not? How long it is and what's the vessel diameter? You can get all that information from CT. Our contribution was to add a P. So we called it CT-based MLDP to add physiology and virtual PCI to understand what is the optimal stent length based on that predicted post-PCI FFRCT. Now the field is evolving, and there will be a talk on CTO, so just one quick slide, but this field is rapidly evolving that now there's also AI-based detection of CTOs. I talked about the trial in 2021 that has been positive, but nobody does it on a routine basis. Why? Because it's hard to interact with the data. Now, there are softwares out like this that with one button, you click it, does an automatic AI-based detection of the CTO length, and you can see how you can display that in a 3D model and correlate that with the angiogram. So it's becoming easier to digest and interact with the data. Now, as we do these procedures live, this is all shifted from pre-procedural planning to live guidance. This is what we've done in our cath lab on the left as part of our participation in the P4 trial, where you get the CT 3D models of plaque and calcium, and as you rotate the C-arm, you can see how the CT model moves. This is helpful because therefore you reduce foreshortening. Let's say you're doing a CTO or a lesion that you don't know where to push the wire, you get an understanding whether the vessel is tortuous or the anatomy, and there's a number of initiatives to create this co-registration from various vendors. Now, in the document from SCAI and SSAT, as I wrap up, this is not yet prime time for numerous reasons. There's a number of barriers at sites. I can tell you that I went to practice after fellowship, and even though I knew how to read CT, the problem that I had is they told me, you're not a reader. So therefore, you don't even get access to the software because there's a number of restricted licenses and those are only for readers. So I'm sure a lot of you are dealing with that. So there are specific site barriers. Not everybody has a good scanner. Does everybody have access to the visualization tools? Clearly, we need more data. Training, Manos and I have taken the initiative and others here to train more in people. And of course, these things cost money. So how do you pay for all these things that want to be done? Something that I think has created a lot of momentum, as Evan mentioned, is that I think this has created communication. So frankly, I don't think I have learned as much as I have in the past 3 years as lately because it has taken me out of my silo, right? So now I'm talking to radiologists, cardiac imagers, people from different fields that have been looking at plaque and physiology and calcium from a different aspect, and this has created a great momentum in training, partnership, and initiatives to advance the fields, and a number of us have been with us in Minneapolis for some of these meetings. If this is something that resonates for you, I would invite you to come on October 9th and 10th to our meeting where we're doing our 3rd summit that might be of interest. And I will just wrap up by saying that if there's one message that I can say is that shift from looking just at the report and start interacting with the data. Thank you so much.
That was such a phenomenal overview, really, of the whole field of what CT-guided PCI is. So for someone who's never heard of this, or maybe they just saw the title, but they haven't implemented it into practice, what do they need to do? Do they have to go back and do a 1-year advanced imaging fellowship? Where does it start?
It's a great question. It originally crossed my mind whether that was necessary, but I think I was just talking to somebody outside. I think this field is rapidly evolving, that now there are being purpose-built softwares that are making it just so easy to interact with the data that you do not need to be a level 2, level 3 cardiac imager. And the reality is, a lot of here people are experts in PCI, so they can comment. We don't care about too many things. I just know, is the lesion severe? Is it calcified or not? What size and length of stent? So there are now no softwares that are giving you that information in a very practical fashion. So the answer is no.
Yep. And just to emphasize that course that was highlighted, a 2-day course, you can go back home after a 2-day course. On Monday, you could implement this into your practice, and like anything else, you'll improve on your skills with some practice. But this is something that, thanks to the software advances, you can implement after 2 days. You're comfortable to implement this in practice.
Also, there's a microphone here. Anyone has any questions from the audience, just raise up your hand. We'll go over and give you the mic.
Perfect. I think we're just right on time. So, it's really my...
There's one question.
Oh, there's a question. Go ahead. Oh, sorry, go ahead.
Great talk. Since we were talking about CT and guided PCI, so in our Center for Hemodynamic Support, so the TAVR CT that sometimes we use to decide if the patient can get Impella on which side. So just add to your momentum about using CT pre-PCI planning. I think that's for access also very important.
It's a great point. I guess since you bring it up, when we started writing some of our first research papers, peer-reviewed manuscripts in this field, we got a lot of criticism, like, why are you saying that you can use CT for access and those things? And we're like, well, we're saying in the CT that it's a bifurcation, true 1-1-1 Medina, so therefore, go with at least a 7 French, slender and good support, and ask for 2 wires. So yes, you're right. There's a lot of lessons from the structural experience. I'm really pleased to introduce the next speaker. I alluded to him during my talk, Farouc Jaffer. No, some of us are talking about this, but Farouc had the vision that he's been doing this now in research and educating about how to use CT for CT or PCI for many years, and he will talk to us about CT for PCI step by step.
Thanks so much, Yader. Thank you, CVI, for the invitation, and it's a pleasure to be here. That's a very kind introduction. The reason I was involved in this field is really we had just so much outstanding CT radiology at Mass General. Some of the first seminal papers from Achenbach and Hoffman and others, Sunny Ibarra, Brian Koshadra. So I just had to absorb a lot of smart people talking about things, and it was great. And now it's really pretty amazing to see how this field is really starting to implement this in more routine PCI practice. So you've seen some of these images. I'm really it's a part of it is going to be reinforcing what Dr. Sandoval just shared. But there is so much that has now been available for us to look at on CT. And as really mentioned, I think our company's HeartFlow clearly bringing these in digestible formats to us so that we can use them at point of care in a minute or two is really what's changing our ability. So while there's a lot of terminology, as mentioned, ultimately we're interested in really understanding how we correlate CT information with our X-ray angiogram, and these reconstructions can really help and get at those things that are super important to understand in terms of planning, and we'll get into that. So the key aspects of this have already been mentioned, understanding the data, and when they're presented easier and easier, we're going to use them routinely, just like we've been looking at old angiograms if they were available, but we're going to get a lot more information. So the lesion morphology and aspects of the lesion are critically important, in addition to understanding calcium and bifurcations for total occlusions. One other area I think which will be interesting is looking at high-risk plaques in the cath lab, especially with the recent PREVENT trial, and we're going to be aware of these much more often ahead of time. So for non-culprits, near our culprit lesion or in other arteries, we're going to have some insights. The CT FFR and pullback gradients are going to be increasingly important, I think, as we understand how we attack diffuse disease versus should this be a PCI case, should it be a bypass case. We're going to learn that more and more. Myocardial mass, very interesting, multiple software packages available to really now understand, is that diagonal side branch significant? We most sometimes have many branches to try to protect. Wouldn't it be great to protect the ones that are actually going to cause larger MIs and focus on those preservations? The mass can do that for us. Guide choice and virtual stent planner tools have been alluded to. So one of the first things, just to re-emphasize, we know this, that calcium detection is clearly limited on fluoroscopy. CT with both conventional and dual source markedly improved our ability to detect calcification and help us not underestimate the complexity of lesions. And now with photon counting CT, it's just hitting a new level. While these systems are not routinely available, there's probably under 100 in the world, they're growing in terms of their dissemination. Seeing calcium at 200 micron level thickness is now possible. So this is absolutely a spectacular advance in terms of resolution. We know that CCTA is really well suited to what we want as interventional cardiologists. We've learned a lot from the intravascular imaging world, both from IVUS and more recently from OCT, and Evan's been a part of this. Really understanding aspects of intravascular calcium that are going to change our focus on how we predilate, how we treat lesions, how we do advanced lesion preparation. And the things that we care about are typically calcium length, calcium arc, and calcium thickness. And increasingly, CT is getting at all three of these. Certainly length and arc are approachable. Thickness is now going to be more and more approachable as we move into the photon counting era, because we're going to have less blooming artifact. And so when we get at these three, we're going to be able to really match our guidance. We know that as we increase factors of calcium complexity, advanced lesion preparation is going to be necessary for stent expansion. Why have to guess at that when you have CT increasingly available ahead of time? We should be able to have a sense of that way ahead of the procedure. We can see here in one example, this is one of the original position papers in the Euro intervention from the European experts in CT, really helping us understand, here's an X-ray angiogram, a CT angiogram, the maximal planar reconstruction, and then what calcium looks like on those axial cross sections, really our most important thing. You can clearly see circumference. Again, these are with older scanners, so there's a decent amount of blooming. The side-by-side OCT image is really helping us understand, okay, this is really going to be validated. The first time we're going to do this, we're going to be, before we do blind CT guided PCI, we're going to be doing a lot of intravascular comparisons. These are the types of images you're going to want to see and compare. And then ultimately, we have physiology to help guide us. We can see a clearly steep drop-off here in the second to right panel. And then using virtual PCI planning tools, we can understand where to place our stent, how long they should be, and what our delta FFR gain is going to be ultimately. So it's going to really help us not leave untreated disease behind, as you've heard today. That is one of the major causes of refractory angina or post-PCI angina, is not treating unrecognized disease. A little word about the gradient, how we pull back. I think we've understood this for a long time when we see diffuse disease. Carlos Collet and others had this concept of now quantifying this using wire-based approaches with pulling back of an FFR wire or IFR wire and watching the actual slope of the pullback. We know that when we see steep increases, that there is usually a very severe focal lesion, and it turns out those lesions that have severe steep drop-offs in their lesion loss of pressure are associated with thin cap fibroatheromas, more vulnerable plaques, and those are the ones in an outcome study that actually do better with PCI in terms of their event rates. And so diffuse disease is a much different problem that may be still approachable in the cath lab, but you need to know it's there. And these types of measures can now happen from CT almost up front when we see those slow drifts in color change. For bifurcation planning, also an essential tool. You saw this image earlier, but really the ability to understand, are we going to have significant FFR drop-offs in side branches? We're going to have lots of choices in side branches. Diagonals, I think, are perhaps one of the more vexing ones because they don't look very big, but they run very long, and they actually supply a decent amount of myocardial mass. Sometimes having that quantification of FFR drop right away or myocardial mass measurements is going to help us focus in on that. And then we're going to understand, at least at the very least, we need to wire those branches to keep them open and decide if it's worth an upfront or bailout provisional strategy. And then the final point, most of this will be covered well by Dr. Shah at the end of the session here, but in CTO PCI, the reason it's so incredibly effective, and we have a randomized trial as mentioned, is that there is a tremendous amount of proximal cap ambiguity. X-ray angiography cannot see between the proximal and distal caps. CT, of course, has soft tissue contrast that can. For long CTOs, seeing the vessel course is very helpful. In segment calcium, you're never going to estimate. The randomized trial was mentioned. It improves PCI outcomes, and there was a trend to reduce perforations as well. And in addition to doing pre-procedural planning, which is incredibly important, there's also opportunities to do real-time planning. Here's an example of seeing a high complexity JCTO score of 4 in the right coronary. We know this is not going to be, we should never be doing single guide CTOs, but this is clearly, we're going to need all our options here. It's nice to see that there's not a huge amount of calcification along the body. It means we should be able to traverse this segment with kind of more routine strategies. And for real-time work, that's another option here, if it clicks. Okay, there we go. You saw this tool. So AI-enabled tools also are really helpful. So those features that you saw are great, but we should be able to see even more detail to understand the complexity of CTOs. All the scores that we know CT does a better job than X-ray angiography. at guiding, engaging the complexity of CTOs. They're all going to be automated for us. We shouldn't ever underestimate the complexity. That often happens with X-ray imaging, fluoroscopy, because we have incomplete angiography. We're not staying on long enough to fill collaterals. We're not focusing on CTOs for many angiographers. One little aspect of how this might be used also is to guide more complicated procedures like dissection reentry. This is an example of having an overlay of CT angiography with calcium showing an unsuccessful reentry zone because the reentry point was at a block of calcium. When we were in between two blocks, this was a successful point. So being able to guide in real time are some other aspects that you'll see, and we'll hear more from Dr. Shah about this. So just to conclude, we really have a step-by-step approach for understanding how CT can aid in PCI planning. It can tell us many important parameters about anatomy. It also gives us insight into physiology, a number of important aspects there. And then finally, more recently, in real-time CTO fusion, I think we can also understand how to treat more complicated CTOs. Thanks so much.
For a great presentation. Maybe stick with us since we have a few minutes, and maybe I'll start with a question to you, and maybe we can shift it. I'm thinking about Lorenzo and Kate here. I mean, you guys are, and I know that there's others, but that do just the most complex CTO lesions, referrals, at high volume. I mean, like, can you speak about, with some degree of skepticism, I mean, what is the role of CT for CTO, particularly for the very skilled operators? Is this just the latest sexy tool, or does it actually help? I mean, I'm sure there's some skeptical people in the audience. I'm interested in your opinion, and maybe I'll pass it to Lorenzo and Kate to just a real opinion on what's the actual value of this.
Yeah, I think without being too dogmatic about how much value it adds, if the roadmap is available in the cath lab, we're constantly looking at it. It's just like any other roadmap that we would have for PCI guidance, as you've already shown. The areas that I think it is really helpful for is when we're doing stiff cap penetration of the proximal cap, stiff wire penetration of the proximal cap, and there's concerns about ambiguity. Having additional roadmaps, knowing where the side branches are between the side branch angle and the main branch angle, that's particularly helpful. Long dissections, when one is potentially prone to deviate off course into RV marginal branches and RV branches, this can kind of keep us in gear. So there's some aspects, but I have been doing it a long time, and I'm sure I have that inherent bias. Certainly happy to hear Kate, Lorenzo, what do you guys think about it?
Yeah, definitely. Also, I would talk about CTO planning. For sure, failed CTOs, you really need all the information to be able to maximize your chances of success in the next procedure. It's very useful for CTO PCI in post-CABG because you can see where the grafts are located. Many times you don't have the surgical report. The patient comes from another hospital, was operated upon like 30 years prior. So you can see on the CT where the proximal anastomosis are, the distal anastomosis, the angle, as well as all the things that Farouc brilliantly discussed. And yeah, sometimes there are jump grafts that you're not even aware they're present, or you think there are, and then maybe there's some miscommunication on the report, and then CT just clarifies that. I don't know, Kate, what's your opinion on that?
Yeah, I think not growing up with it, we don't have the overlay, and logistically it's often challenging to get our patients a good quality CT remotely and get it transferred and look at the images rather than the report and all those types of things. So, but I think looking back on it, where we always would go for it were post-CABG failures, trying to figure out many of the issues he said. So there's other ways to figure out ambiguity in a lot of cases. We base power knuckle, et cetera. But I think there are always those ones where it's hard to figure out exactly the course of the right's a little odd, or the marginal really overlaps, or something that you can imagine if you knew that and you had no visualization that you would be smarter for that. And so when I reflect on it, sort of like, IVUS helps you make decisions in PCI and really ramp up your algorithm because you get that immediate feedback. And I imagine that CT also gives you that corollary feedback of these decisions you're making, and you see, what is going on could likely accelerate that too. So I think, some things, like many times we can see calcium there, so maybe that doesn't help as much. But other times where it's really ambiguous and you're trying to figure out, which is it. Does it come off the diag, or trying to get in the LAD, or especially lots of branches, or poor visualization, where I wonder that would be helpful. But Wissam, what's your practice? You guys are a high volume lab.
Yeah, I mean, it's a great thing here, CT, and obviously there's no big disagreement on the ambiguous courses, ambiguous cases, failed CTOs. But a question for you, Farouc, and maybe Yader, how often are you doing CT scans? Like, what's the percentage of your patients that get a CT scan before a CTO or a complex PCI? Are you doing it on 60, 70, 80%?
Yeah, sure. No, it's not that high, and I think it is important to understand there's two categories. Increasingly, CT is going to be available as our gatekeeper entrance into the cath lab. Those patients, automatically, we just want to extract that information and use it. It's free, just analytical tools. Dedicated ordering for CT is really in two situations for me. As mentioned, post-bypass, with concerns of incomplete diagnostic angiography. There are some aspects of stented vein grafts that are helpful to know. If a graft's been stented, the chance of retrograde use is much lower. It's also nice to see if the distal hood is patent. That helps on some of the retrograde and antegrade aspects of traversing those grafts. Sometimes you get into ambiguous zones in the graft. So having that information is very helpful. I think the other time I end up ordering a lot is when there's just incomplete diagnostic angiography, or if there hasn't been angiography for several years. I don't like to send those patients back to an invasive cath. I will just order a CT, hopefully at a good center, and then we will be able to spare them an invasive procedure and then go straight to CT planning.
Thank you, Farouc. I think we're going to shift to the next talk. Thank you so much. So it's really my pleasure here to introduce my co-moderator, Dr. Shlofmitz. He leads the imaging group at St. Francis, has been a real champion in imaging and physiology, and he will talk to us about the virtual PCI planner.
Thanks so much. So we'll be talking about virtual PCI planner, but more specifically, how to integrate these tools for virtual PCI planning so that you can come up with your strategy, just like we would with structural heart interventions, by the time that we get to the cath lab. And you can see, hopefully, how it makes us more efficient, but more importantly, more accurate, and come up with the best outcomes for our patients. So modern physiology, whether we're talking CT-based or wire-based, angio-based, hopefully is way beyond just this red light, green light of should I do PCI and what the absolute value is. We know that ischemia is a continuum, and importantly, with CT-based physiology, you can actually determine exactly where ischemia is and where on that vessel it's contributing to the ischemia. And this has been validated with prospective studies that because of that, you could then determine if you were to put in a 12 millimeter stent or a 38 millimeter stent, what that impact is going to be on the post-PCI physiology. So we could actually predict what our post-PCI outcome is going to be from the baseline, and that's very helpful for procedural planning. We want to know before we get started what sort of outcome can we achieve. So that brings us to the virtual PCI planner. This is from the paper that Yader mentioned, the consensus statement, where you see that you can actually strategize. Before what happens very often in practice is we pop in a 23 millimeter stent and it's inadequate. And then you put in another stent. Sometimes you have to put in another stent. So we shouldn't be testing on our patients like they're guinea pigs. We can do this on an iPad or on your phone, where you can see two different strategies and you can see how it impacts the ischemia. So you could test out a strategy virtually. This doesn't take a lot of time. It's a couple of clicks, and we could come up with what the best strategy is for our patients. So I'm going to walk you through a case that hopefully will help to illustrate this. This was a young patient, 42-year-old, came to our ER complaining of worsening exertional symptoms. As with most of our patients who come in with chest pain, underwent a coronary CTA. So our reader, Rusha, is here, and as very often that she does, she sends me these beautiful pictures with her photon counting CT, and this young patient, exertional chest pain, we see right off the bat, has a lesion in his mid-LAD. And what typically happens here is you get this report, patient has a severe high-grade stenosis, patient needs a cath. Just like how we interpret with a nuclear stress test, exertional symptoms, positive stress, and this is essentially the pathway. It stops there. That's really it. We look at the CT report, and then we're done, and we do our usual diagnostic angiogram. You take your pictures, and you try to figure out ad hoc in the lab, what do we do with this patient? So we could stop there, do our regular angiogram, where we could actually really interrogate this CAT scan, use the tools that we have to figure out what are we dealing with. First of all, does he need a cath? Are we planning revascularization? And what sort of strategy are we going to deal with? So some basic things, the roadmap analysis from HeartFlow very quickly hones in on the area of stenosis. Importantly, physiology. So FFRCT, is it that, we know anatomically the amount of stenosis doesn't necessarily mean that that's contributing to the symptoms, to the ischemia. So it's important having objective value. And here we see with the HeartFlow FFRCT that yes, there's ischemia. And importantly, this isn't just ischemia in the distal apical LAD. This is in a more proximal area. There's a relatively focal area of significant ischemia that needs further evaluation. Using the virtual PCI planning tool, essentially you can click on a couple of locations and you can model different stent lengths. And what it'll tell you is if you put in a 9mm stent, what your post-PCI residual ischemia will be, and what if you put in, as in this case, a 34mm stent, will you have an adequate post-PCI result? So that's the virtual PCI planning. What, for me, changed completely the way that we approach virtual PCI planning was this plaque analysis that was recently introduced. If you haven't seen it, this is the game changer, because this makes it that you don't have to go find your CT reader, have dedicated software. You could do this at home. You could do this 2 minutes before you go to the cath lab from your office. I often do this in the exam room with the patients. I pull this up and show them their CT when we're discussing either the cath that's going to be upcoming or patients who don't go to the cath lab just on medical therapy. It's very powerful when you actually show your patients this. But if you haven't seen this, because I know it's not that commonly used yet, it's a relatively new feature. On the left, you'll see you have your traditional FFRCT. In the middle, we have the multiplanar reconstruction, which if you're not used to reading CT, this is the longitudinal profile on your IVUS, your OCT. And you can go through that, and it tells you a number of things, where the plaque is. You can see right off the bat where the lumen is large, and that's going to be our healthy landing zones. Because CT readers, they're looking for severe lesions. They don't want to miss that. They're trying to highlight where there's a severe stenosis. In the cath lab, that doesn't matter as much. We're looking for where's the healthy, where are we going to land our stent? And in a couple of seconds, you can see that on the longitudinal profile, which is the MPR. On the right, and you also get to see side branches, so you can see how it interacts with different side branches. And then on the right is one of the coolest features. It's the cross-section, which looks very similar to the IVUS and the OCT cross-section. And what's displayed on it, that color-coded, is AI automating plaque detection. So again, you don't need to be an expert reader to be able to figure out what you're looking at. If there's blue, that's calcium. If it's yellow, it's non-calcified plaque. And in a couple of seconds, once you've been given that figure legend, you can determine how significant this plaque burden is. Is it mostly calcified? And what am I going to do about it in the cath lab? What sort of procedural strategy am I going to have to deal with? So just so you see how long it takes to go through it, this is me going through it. You click the cursor on the left. I start typically at the lesion, just like I do on IVUS and OCT, and I start walking my way proximal until I get to a healthy landing zone. I see here that we're getting to more of a normal lumen. I'm taking note of where this is. So in the current version, it'll tell you where it is in relation to the ostium, in this case, 26 millimeters from the ostium. And then I walk through the vessel. And I keep walking through, I'm watching how much calcium is there. Do I need IVL or atherectomy? And I keep going till I get to a healthy landing zone, because that's where I want to land my stent. And as you see, as we're approaching it, we're starting to get to an area free relatively of plaque. And on the lumen profile, you can see a large lumen. So here I'm comfortable as a distal landing zone. I see that 60. Right now, on the current version, you need a little bit of basic math. Take the 60 minus 26, you get your stent. So here we know around the 34 millimeter device would be adequate in covering this lesion. So instead of just patient has an abnormal CT, let's cath the patient, if you spend 2.5 minutes, you determine based on the physiology, they have an indication for revascularization. There's minimal calcium in the mid-LAD, so I'm not going to need significant lesion preparation. I could leave my IVL at home. 34 millimeter stent will be adequate in covering not just where there's ischemia, but from treating normal to normal, so I don't have to put in a second stent. There were no significant bifurcations that are involved. I don't need a second wire. From the axial view, I can see it's a normal takeoff. I'm not using multiple, this isn't bifurcation PCI. 6 French EBU 3.5 guide is going to be adequate. Also, from the cross sections, you can determine the size of the distal diameter for your stent diameter. This is probably one of the most challenging parts of coronary CT in translating for intravascular imaging. We know that CT undersizes this, so you use what you do. If you only can see the lumen on IVUS or OCT, you simply upsize to the next available stent size. So 2.5 distal reference, I'm planning to go with a 2.75 millimeter stent. So, all right, let's go to the cath lab. Now we have our plan, we have our recipe, all the equipment's in the cath lab already. Let's see what we find. So I take some initial pictures and have our plan, and I was very underwhelmed. I see a little bit of stenosis in the mid-LAD, but there really isn't that much there. And it was funny because I was going over the CT with a couple of people in my lab. We have imaging specialists. I had them already imaging, intravascular imaging was set up, ready to go. Tell them it's a planned PCI. And they're telling me, all this, look, there's barely a stenosis. It's a mild to moderate mid-LAD stenosis. Let's send the patient home, we're done. Tell them, all right, keep opening the equipment. We're gonna go on. I trust the CT and what it shows. So I decided to further interrogate this and do invasive wire-based physiology. This is the IFR, and you see that at 0.84, significant ischemia, just like we saw with the CT-FFR. And we can do our planning, and it shows same thing with the 33 millimeter stent. We can relieve that ischemia. And then we do intracoronary imaging. And what you're seeing here with Abbott's OCT is right here, exactly like the CT showed. There's severe stenosis at the mid-LAD. There's a lumen area less than 2, so you have an MLA of 1.65, which is really significant stenosis, that because it's largely a centric plaque, it's missed on angiography. Angiography is not an optimal tool to evaluate a coronary vessel because all it is a 2D luminogram. The CT optimally evaluates this much closer to intracoronary imaging actually than angiography. So we shouldn't really be comparing always CT to angiography. It's really looking at, is this the same standard as intracoronary imaging? So OCT demonstrated the severe plaque. We saw the ischemia on invasive-based physiology. Go through our usual MLD max. We get our stent length from the OCT, which shows the exact same thing, treating healthy to healthy. It looks just like going through the cross sections on the plaque analysis, and we get our distal landing zone, and coming up with OCT, we see a 34 millimeter stent is gonna be able to optimally treat this lesion. We get our diameter from OCT. Again, everything's automated, but shows the same thing. The vessel size here is 2.9. You round down with intravascular imaging, takes you to that same 2.75 millimeter stent. We know we need to post-dilate proximally, and then it's just opening up equipment and following the recipe. So exactly as we found from the CT, is what the invasive imaging and physiology showed. And all that information you could essentially get. You know, I still believe there's added value of doing intracoronary imaging and physiology. The big thing is for the post-PCI optimization, you can only get that information from intracoronary imaging, so it's not an either or, but I believe it's synergistic. And most of the information, as Yader had mentioned in his talk, that MLD that we use in our pre-procedural planning in the cath lab, we could get all that information before the patient ever gets to the cath lab. And this is the final result. So as I showed you with the plaque analysis, it took a couple of seconds of basic math with the current version, but this is the latest that's coming down the pipeline. So pretty soon, we're gonna have the next generation of plaque analysis and CT planner where everything gets integrated, where there's some additional features. Not only will we be able to plan actually the stent length, so for interventional cardiologists who don't wanna do simple math, you don't have to anymore, but there's a lot of extra added features where, to me, one of the coolest things is the myocardium at risk feature. And this changes everything for bifurcation PCI, because you could determine, do I want to protect the diag? Do I want to treat the diag? which vessel is contributing to this, and this is the next phase of, this is coming down the pipeline for the PCI planner, and it really can transform your practice. And again, you don't need dedicated software or the license, which are very difficult to get in order to have this. I look at this, at any conference when I'm on an airplane, I pull up my cases for Monday morning, and I just go through all my cases who had CT and come up with the planning. And in less than 5 minutes, you could come up with your whole procedural plan. So with that, I'll open it up for discussion.
Great presentation, Evan. Let me ask both here, Arnold and you. I mean, you guys are expert imagers and physiologists, and you were alluding to this in your presentation, doing pressure wire and imaging. So let me be provocative. Is this complementing or is it competing? Is this coming, I mean, are we going to do everything CT-based? Or can you maybe, Arnold, can you maybe Evan do afterwards?
Yeah, I think it's complementary for sure, and it can give you an idea of what you're walking into, so that you have to do less things ad hoc. You can better plan what you're doing. I would give some caution with the PCI planning tools. I think I showed you this article from just last month, which showed that even the FFR and IFR planning, the simple math that you mentioned several times, could be wrong about 1/3 of the time in terms of post-PCI physiology. And I think that's the concern. Ideally, these tools, especially the CT tool, would actually make a recalculation based on increased flow after fixing your particular stent. So I'd like a reprogramming, a reanalysis, and that's not always the case.
Yeah. I will just add, it's not that it's an imprecise tool. We're imprecise physicians. I can follow the recipe for expansion. I don't get 100% expansion 100% of the time, and that's looking at an ideal setting. So that's also one of the caveats is, even if you follow the tools, you can get an optimal result. But you're not making the plaque disappear. We're decreasing the stenosis. So that is one caveat as well. But there's no perfect tool. But I think it's certainly partially also why I'm doing invasive physiology in these initial cases is validate. Everyone goes through that experience where they self-validate this information. And at some point you see the validity of it and you trust it, and then you can walk without it. So I think always imaging is going to be synergistic. I do believe this is going to start this with angio-based physiology. Is going to replace wire-based physiology, in my opinion. The future is going to be limited to microvascular assessment.
I know we're a little bit behind, but I think this is a unique opportunity. Charlie, let me put you on the spot. This field doesn't exist with all these tools. You invented this thing. We're talking about it now, but you had the vision for this years ago. Do you mind just speaking on this, just giving a word?
Can you hear me? Yeah. Well, first of all, it's just a little surreal to see all of these presentations and just to see where it goes. We just developed a tool to try to help understand physiology non-invasively. I'll talk a little bit about this later. But, Evan, you commented about, obviously, it's not an either-or. It's absolutely not an either-or, right? You have non-invasive imaging first to help decide which are the right patients to go to the cath lab, which need further evaluation with invasive physiology. And I'll tell you, the first time I met Nico Peels and Maria de Bruyne in 2010, and they're responsible for the name FFRCT because they said they want it to be known that it's FFR, albeit derived from a CT scan, and have been incredibly supportive. And it's simple, right? It's thinking about how do we leverage non-invasive data first, identify the best patients, go to the cath lab, and hopefully provide some valuable information for you when you're in the cath lab. Obviously, no test is perfect. There's a lot of room for improvement with the technology, but it's fun to see how you're all using it. So thank you.
All right, so we're going to go on now so that we'll talk about CT-guided PCI in prior CABG patients, and I welcome Dr. Luisa Dallan.
Thank you so much for the introduction. And I want to thank the organizers, Dr. Shishabar, and everybody here. Thank you so much for coming today. And our presentation here today is CT-guided PCI in prior CABG patients. Thank you so much, Manus, for inviting me for this presentation. And well, I think that my predecessors here, they have done a great introduction of the importance of CT guidance in all the scenarios. So I think that for the CABG is a challenge scenario. So all the information that you can gather is important so that you can have a great planning once you go to do your PCI, right? we know that we have improved outcomes when we are able to better triage and plan cases prior to the patient being in the cath lab. And we can address both anatomy and physiology as it has been shown here before. So this is a slide from Dr. Sandoval here that showing that what should you see when you are doing the pre-CT for the procedure. So it's very important to get all the information that you have. I love Dr. Farshad's comment that it's important not only to see the heart, but you have to see everything else that's around. For example, to get large bore access for protected PCI, we know that if you don't do a good job, if you go there, for example, put an impella with a patient with a peripheral artery disease, you can have up to 30% of complications in your procedure due to the large bore access. So it's very important to gather all the information once you go to do a complex procedure, right? You can choose your guide, you can do a plaque assessment, calcium characterization, so that once you go there, you are prepared to do what has to be done. Very important as well, the physiology. I think that Ivan just spoke a lot here about how to go step by step through the procedure, and he has shown the heart flow. That's a great tool that you can send all the images to the company. They can send you back all the treated images so that you don't have to crush your head too much, so that you can have all the information, and in a few minutes you can decide what's the best approach to be done for your patient. So once again, another slide from Dr. Sandoval. I love this slide because it shows exactly what you have to put in mind. What's the difference between a straightforward case or a complex case, right? So a straightforward case, you can do at any time, anywhere. You can do as an ad hoc, and you can have great results. But if you have a complex case that you could see up front that was coming, then you can have a better planning to do the first case in the day, so that you are rested and to prevent something that was not planned to come forward. So I have 3 cases to show here. This first case is an old patient, 80-year-old male, hypertension, diabetes, hyperlipidemia, with prior CABG 15 years before, with prior PCI to the circ, and a new onset of chest pain, even on mild exertion. So the echo showed that he had an ejection fraction around 50% with viability in the anterior wall. And as we're going to see, the angiogram showed the CTO to the LAD, CTO to the RCA, a patent graft to the RCA, but an occluded lima to the LAD. So this is the angiogram showing that you have a CTO to the mid-LAD. And this next image showing the patent graft to the RCA and occluded lima to the LAD. When we did this procedure, we didn't know if I couldn't find the lima or if it was really occluded. So the idea, we team up with the heart team, and the idea was to first see if the lima was really shut down, and second, to use all the imaging, all the plaque characteristics of the native vessel so that we could plan the treatment of the CTO to the LAD. So we performed the CT, as we're going to see, confirming that there was an occlusion to the lima to the LAD, and a plan for the PCI to the CTO. With the images of the CT, we were able to choose the proper guide to plan for a atherectomy with shockwave because of the calcification, and not expecting so much challenging features, right? So first of all, we were able to see that the lima was occluded. We could see the native LAD showing a lot of calcification and the occluded vessel. And we were able to see other vessels. So for example, this stent to the circ, we were not able to see inside the stent because of the features of our device. But as Dr. Sandoval and Dr. Ivan here showed before, we have great new technology where you are able to go and see inside the stents. And this was the patent graft to the RCA. So with that, we were able to do shockwave and finalize the case successfully. Right? Second case, an 87-year-old female with prior CABG 17 years ago, with multiple PCIs to the LAD, to the circ, to the first OM, a lot of stents, with refractory chest pain, even for mild disease, for mild exertion, like doing physical therapy. And the echo showed a preserved ejection fraction of 55%, viability to the lateral wall. And the idea was to do a pre-planning with the CT of the coronary. So here, showing exactly the opposite as the prior patient. So this patient actually had a patent limit to the LAD, and the graft to the circ, to the OM, was occluded. So in this situation, we were able to see in the CT that there was a lot of disease. So we have the stents, and in between the stents, you had a lot of disease with a new restenosis of the vessel. So based on the CTA pre-procedure, we were able to choose to plan for the procedure, thinking of doing to treat the in-stent restenosis to the circ. And the plan was to do an appropriate guide selection for the procedure, planning to do an atherectomy using Wolverine, using laser for the in-stent restenosis, and use shockwave, everything guided by IVUS. So here we can see in the left picture that there was an occlusion to the first OM and in-stent restenosis to the circ, and the disease was going up to the left main, right? So the idea was to treat the in-stent restenosis to the circ and to treat the left main at the same time. So here is a native circ showing that with the stent bush that you had even stent fracture inside. So that most probably that stent fracture was the cause of the restenosis, right? So in this situation, they perform pre-dilatation with a non-compliant balloon and a Wolverine balloon, laser atherectomy, shockwave. And then at the end of the day, in the picture to the right, you can see a final result, a great result with a patent left main and to the circ. In the final case, this is a patient, a very challenging case, a 65-year-old male, hypertension, diabetes, hyperlipidemia, prior CABG 10 years before with PCI to the circ, highly symptomatic, echo showing moderate ventricular dysfunction, lateral kinesia, and moderate anterior wall hypokinesia. So they have attempted, this is a case from Brazil, from Dr. Arada in Brazil. So they had tried to integrate CTO to the left main, to the LAD. It was unsuccessful. So at this point, they have to get all the information that they could so that they could plan to do a successful procedure, right? So they did a CTA showing that there was a patent Lima to the LAD, but the LAD had a lot of calcification. So based on that, they decided that they needed more robust help. So they went to Seattle with the team of Bill Lombardi, Katie Kearns, and Dr. Lorenzo Azzalini, and they invited Lorenzo to go to Brazil to perform this procedure in a CTO course. So the plan here was to go with the rotablator through the native, through the Lima to the LAD, through the left arm. So the idea was to cannulate the Lima through the left arm and to do the rotablator through the Lima into the native LAD, just for experts, right? So Lorenzo went there to Brazil, and they had this image, the double injection, showing the patent Lima to the LAD, and this a lot of calcification to the left main and the native LAD. So this is the rotablator from the left arm through the Lima inside the native vessel. Do you remember this, Lorenzo? Oh, yeah. So this is the rotablator through the Lima. Once they did that, unfortunately, there was some dissection of the Lima as it could occur. So, thankfully, Lorenzo was there, and he just placed a couple of stents in the Lima. And at the end of the day, this is the final result, great result with patent Lima, and a great result to the native LAD. So, great case, Lorenzo. So to finalize, the key learning points here are that the CT guided PCI allows to shift from the reactive to a predictive intervention. So instead of reacting to what you're finding in the angiogram, you can predict how you're going to treat the vessel once you get to the cath lab of the patient. Improved outcomes with better triage and case planning pre-procedurally, as we spoke before, and improvement in decision-making by doing the CT pre-procedural. Expectation is to widespread the adoption of CT for PCI planning and guidance, especially for patients with prior CABG, and this should be definitely included in the interventional cardiology toolbox. Thank you so much.
That was great. Thanks, Luis. And such great examples, different ones showing how it really lets you know everything that you're going to deal with up front before you ever get to the cath lab. So it's perfect examples. So, Salman, what do you think now? We've seen a couple of talks that really emphasize how this shows you what you're going to deal with. Not just do they have an indication to go to the cath lab, but what are we going to do in the cath lab? Where do you see the future of non-invasive stress testing versus CT, in the primary cardiology practice? Where do you think the pathway should be for the workup of chest pain?
Great question, Evan. So, so of course, as we've seen, even in practice, we are ordering more CT for diagnostic purposes. I don't even remember the last time I ordered a stress test, predominantly mainly for assessment of functional capacity. We're actually getting more and more referrals, especially for CT or PCI, without a diagnostic angiogram. We're actually getting CT referrals based on CT. Patients have lived far away from 4 hours away. They've had a CT at the outset hospital, and now they have a CTO, and they are getting referred for CT or PCI. And those situations, we're actually not doing a diagnostic and just proceeding with just a dedicated CT or PCI procedure. So I think that's where we're going to see the trend change. And of course, if you look at the CT-CTO trial, we have seen that the patients, there was benefit in terms of success and a trend towards reduced complications. But at the same time, the benefit was more in complex CTOs. So I think CT is going to be the way to go in a lot of these procedures, not only for pre-procedural planning, but actually as an initial diagnostic test, and then you have to go and do the therapeutic procedure after.
I love that, the bypassing the diagnostic in this complex, for complex lesions. And what's amazing, it also changes the way you consent the patient. It's not just we're going to do a diagnostic angiogram. Up front, you're telling we're doing a complex CTO PCI for revascularization. So, did we convince you?
Yeah, 100%. I have not been using this very routinely, except for very complex CTOs. But I'm thinking, as all of you guys are talking, maybe everybody going to the lab should undergo a CTA before they go to the lab, so that you're prepared when you come in. You know what you're expecting. You're not taking a decision on the fly. You're not bringing the patient twice back to the lab to kind of treat something you found. And you have all the discussion and planning with the patient ahead of time.
Yeah, I think with patients with preserved renal function, it's the same reason why for structural heart interventions, they all come to the lab with imaging. I've had patients where I do the heart team meeting before the diagnostic cath for that reason. It can go, I know that the diagnostic's going to be just a discussion with should we do bypass or multivessel revascularization. I have them talk to a surgeon before my diagnostic cath so that we're able to just do ad hoc complex PCI that day.
Yeah, I would add also that even if the CTA is done for diagnostic purpose to rule in or rule out CAD, then you can always go back to the images and get FFRCT, the CTO analysis tool, so you can use CTA in a dynamic way as a gatekeeper to the lab, but then seamlessly transition to the PCI planning modality.
Let me just a quick question there. And Luis, maybe Luis and Kate, and I know Manos is standing there. If anybody has questions, just raise your hand and we'll bring the mic to you. But Luis, you showed some beautiful images there. And people may be wondering, how do you do that? Is this something that you're doing? You're partnering with your imager, and maybe others, maybe I'll pitch it to Kate and others that want to pitch. How are people doing this in their practice? Are you doing it alone? Are you asking your imager to provide you certain things? How are you executing those beautiful planning that you did?
Thank you. It's a great question. We have a dedicated team in our hospital that they are dedicated to doing imaging. So they prepare the images first, and then we are able to go inside the software and review whatever we need, right? So first of all, a good dedicated team, as you guys have in Minneapolis, that they can prepare these images so that the intervention, you make our life so much easier, right? And the second thing is that if you have HeartFlow, if you don't know how to prepare the images, you can send all the images to HeartFlow, and they can give you back with all the description, reports, and you can play with the images as well.
Yeah, I was just going to say, we've had a little bit of the opposite experience on some of the physiology verification where we've had it looks like a distal left main bifurcation and the circ is 0.5 and the LAD is like a really diffuse, really marginal IFR negative FFR kind of thing. So I think we've had enough of those cases that I haven't totally jumped on to trusting some of that. And I think that is part of the learning curve. We're still relatively new to CT FFR. So part of it is also you probably have to keep reevaluating this. It's not oh, well, that means we can never rely on it. Sometimes we can. Our institution is learning, we'll get better at it. And I think everything else new, it's good to have a champion. So we have someone who does some imaging for our structural team, who's a CT reader, and our other CT guy is quite busy too. So having two of them and going with a specific question is very helpful for our planning purposes. And also just, knowing who to ask to request some of the reconstructions that just really help us that we otherwise aren't always getting projected to us where we can see that outside of the reading room. So it's just some simple efforts that once you know who to call, it really lowers the barrier, I think.
Yeah. One point, with the physiology, 'cause when I first started using heart flow, I was very skeptical for that reason, because it was frustrating. You'd see, this is in full indication for PCI. You bring them to the lab, you repeat it, and it went from positive to negative. And I had a couple of these where it just kept happening. I was a little skeptical. And what's interesting, when I stopped, looking at just the value of the CT-FFR and really looking at, because sometimes what gets reported is the lowest CT-FFR. And if you pull up the interactive, if you see it's in the apex, somewhere you would never put your physiology wire, you're never going to revascularize, and then you move your cursor to really, what's the area that I'm going to treat? And so what's happened, that's helped tremendously with the accuracy and the reproducibility of not, because sometimes it gets reported just, CT-FFR 0.74, but when you pull it up, it's in the apex, and if you look in, the mid-LAD, it's 0.95, you're never going to bring that patient to the lab. And I've told patients their CT is non-obstructive disease, I'm not cathing them even. I get a call from the referring, but they have an abnormal CT-FFR, and you have to explain it's abnormal in a place that's medical therapy.
Yeah, I think that's helpful. We've had some where it's showing more proximally, and so I'm curious for you all if that was different imaging, or is it just getting comfortable with the software? It's one of those things when you know how to troubleshoot your invasive physiology, then I can trust it. I just don't know how to troubleshoot the non-invasive physiology, so.
Partly, I think data in, it depends where it's being done. So photon counting is going to be more accurate than non-photon counting. Where they give in nitrates, beta blocker, what the image quality is. So, part of that, I think for everyone, it depends on your local area. I know if it was on our Neotom Alpha in our hospital with our CT readers who are experts at it, it's highly accurate, where across the street, they can do the CT same day, which a lot of patients like not to have to wait. But they're just high, but they barely give beta blockers, and people's heart rates are 90 when they're getting these CTs, and honestly, it's garbage scans. So they all come back abnormal. Everyone comes back abnormal, and those are always, I know in the cath lab, those are normal, and you have discordance, but I don't think it's necessarily a limitation of the technology. It's more, how do we acquire the image? Just like if a limited angiogram gives you limited information, the higher quality, the input of data will allow you to make the most of it. But of course, nothing's perfect, and it's continuing to improve, I think, with time. So, for the sake of time, we'll go on. Yader is going to talk to us about CT guidance with calcium treatment.
Great discussion. Maybe, Arnold, very quickly, because I know you're the physiology expert. If you want to validate the CT-FFR, do you do a non-hyperemic pressure ratio, or do you do FFR?
Because the FFR, it's only correlated to the FFR. You're going to have more discordance with
This is a good point. We can talk more offline, but I think it's an important issue that came up there. So, all right. So, we're just a little bit behind, so I will, stick with me for now calcium. I would say, as you probably gathered, I think the field started very heavy on CT-based physiology. If you ask me, I would say that right now, there's an incredible emphasis and interest in CT for calcium. I think many here all over have been, fighting calcium in the cath lab for many, many years. But there's been a transformative journey for using CT now for CT-guided lesion preparation and calcium modification. It used to be, that's what I was taught when I was a resident fellow, and what I probably have told other trainees, that say, don't use CT in patients that have a high calcium score. There's, blooming artifact, it's a limitation, we can't say nothing about it. But look at this image. Same images I showed before. In one image, just looking at the MIP, the maximal intensity projection, and looking at some of those cross-sections, it does not take a 1 year, 2 year advanced imaging fellowship for all of us to understand that this is a total headache in the cath lab. So with one image, we all understand this is severe calcification, it's concentric, this should not be done at the ASC at Friday at 4 p.m., right? It's a very complex case. So therefore, there's a transformative journey of CT that it's now being used to guide procedural planning. Now, a lot of you may tell me, well, I can get this from IVUS or OCT, and this is just some latest gadget. This is one of my cases from a couple of months ago that I had that was probably one of the most recent calcium nightmares that I've had. As you can see, very calcific LAD diagonal. This is a microcatheter, uncrossable lesion, cannot get IVUS across it, but from the CT, I already knew that it was a bone, that it had concentric calcification, where the calcium was located, that there was maybe some area that had way more calcium density. So I won't go through the whole case here, this video clip, but just to tell you that, yes, there's imaging, but there are cases that many of you do here that I cannot get an imaging catheter across. So therefore, CT will tell me the nature of that morphology before I enter the cath lab. So in this case, we use a Javelin off-label peripheral. We are complemented with orbital atherectomy, with OPN, and we knew all of that. I think you mentioned predictive. That was our plan, right? We were planning to deal with calcium. So again, back to the same concept, just to reinforce some of those elements. You want to use this MIP because it's an easy image, one click with any CT visualization software out there that will rapidly tell you is the lesion calcific or not, as shown on the right. Now, and the other important conceptual element that you want to familiarize that has been mentioned many times is NPR, multiplanar reformation. This can be done with any CT software out there. Go to your practice tomorrow, ask your reader, imager, radiologist to tell you, can you show me how to get a multiplanar reformation? Because as Evan alluded, it's your traditional longitudinal view, and you can just do a pullback and understand whether there's any calcium in the lesion or not. What is calcium? Calcium from the CT perspective is defined by Hounsfield units. It's bright, and as shown on the bottom right, it's often defined by Hounsfield units over 300, 320 or so, but it's pretty much based on Hounsfield units, this dense, bright area, and you can look at this Hounsfield units to look at the density. Now, some of you may, again, it's very fair to be skeptical and say, are we sure the blooming is not a problem? This is a very elegant study looking at OCT against calcium. And what we can say right now, it is that calcium is very good for arc and length. So this morphology that we've seen, if it's a 360 arc or 270, it is something that matches very, very, very well as compared to intravascular imaging. Same for length. With volume, as pointed out, yes, it is correct. There's overestimation of calcium by about 160%, and thickness is sort of okay. But calcium arc, that morphology, you cannot fake that. So you can trust that. Evan has already shown of these things. So essentially, it is easier now to find this morphology because there are better tools to look at that. This is now, from the interactive plaque tool, something that is down the pipeline. I don't think that this has been shown yet, is that now there will be very soon an interactive plaque that will give you now calcium on 3D models and multiplanar reformation. So this is a very, very rapidly evolving field in how calcium can be better appreciated now in a very facile manner. There are other systems here like AIQCT that can also show that. So just be aware that as we speak, this is not the future, but this is the present, and there's a lot of interest in understanding how to analyze calcium. Now, I've alluded to the P4 randomized trial just a few minutes ago. So there's the ongoing randomized trial, P4, that is looking at CT versus IVUS. This is the package that you get as part of your pre-procedural planning. So when we have done these randomized trials, I get a 20-page PDF and an interactive 3D model as shown here that now gives me a three-dimensional representation of plaque and calcium. So now think about what's happening in practice in the very adjacent possible future, right? Now you're evolving from morphology and arc and length to now concepts of calcium distribution in 3D models. This is not yet clinically available, as shown at the bottom right. It's been investigational, but be aware that this is what's being tested in the randomized trial and will probably be in a practice, available to you, and makes it way easier to understand where exactly the calcium is located. See this LAD diagonal. If it has a lot of calcium across the bifurcation, maybe you want to treat that a little bit differently. So just be aware that there are new evolving concepts in our understanding of calcium beyond our traditional concepts that have been understood from IVUS and OCT. One of those concepts is calcium distribution. I've talked about the P4 trial. Now, just to re-emphasize some of those concepts of this colorization that you're seeing now in several presentations. What they're trying to do is they're trying to look at the density at the Hounsfield units of those lesions. And this has been well standardized for those of you that read CT are familiar with this, low attenuation less than 30. And what many of the softwares are doing are that either using traditional Hounsfield units or this adaptable Hounsfield unit thresholds based on a specific Canon contrast. They're trying to understand what are those areas that have calcium. Again, this is from the interactive plaque, what they do. One limitation, if there's an imager here, please keep us honest. One limitation is that Hounsfield units can change per scan and per KV, so therefore we have yet to understand how do we standardize this, but this is how these are being colorized for us to better understand. There was actually a prospective study, multi-center, 15 studies called Reveal Plaque, that looked at IVUS against calcified plaque balling, and it showed that it matched very well. The core lab for this was Akiko Mahara, so you can be very confident that these measurements were done with a lot of meticulous assessment to really get to this understanding, but really good agreement between IVUS and calcified plaque balling for some of this colorization. Now, you've seen a lot of this morphology. I want to also in these presentations add to the concept of calcium distribution that the other great interest is this concept of calcium density. So pretty much think about it. How hard is that calcium? Is this something that I can break with a non-compliant balloon, or is this something that I'm going to need more advanced calcium modification, such as atherectomy or intravascular lithotripsy? So again, this is the concept of calcium density. This is where I think CT complements intravascular imaging, because you cannot get at calcium density from imaging that I know of right now. Maybe something that Evan knows in the pipeline, but this is right now something that you can do with CT. So you can look at the morphology, and you can therefore you can do this with any CT. Right now, tomorrow, your practice, you grab your cursor, you hover over the calcium, and you query what are the Hounsfield units of that segment. If it's maybe 300 for 100, maybe you break that with an NC. If it's circumferential and it's 1,000, maybe we need more. We do not know, but be aware that there's a great interest and effort on this. The original publication on this is from Kurogi. Here they looked at a number of lesions, and they looked at all multiple variables, and they were able to identify that mean density was the best predictor for rotational atherectomy. So just be aware that this is a rapidly evolving field, and just think about this. You can probably put the dots together as we have now this array of tools for advanced calcium modification. There's a lot of opportunities for us to better understand how do we use those tools. Now, this is work from Carlos Colette, Anatomo, and Frédéric Bossit in Belgium. Now, they're very interested in this concept. They just published this in SCAI a year ago, and now they're taking this concept of calcium density from mean calcium density to now understanding is there different density at different areas in that cross-section. And as you can see, there may be some areas that are very consistent and concordant, that the Hounsfield units are all the same. Some of them may be different. We don't know, but again, just be aware that there's a lot of interest in this understanding of how dense that calcium is in a lesion. What's down the pipeline? Because of that concepts that I just alluded to from the pivotal P4 trial, there's the intention to do a P5 trial. This is not yet the final study algorithm, but preliminary what's being worked at. And this P5 trial now, it's going to move the field now to the focus on CT-guided calcium modifications in patients with severe lesions of CT guidance versus IVUS guidance. So understand that this is actually very interesting, right? CT is shifting from something that we have all educated, it's a limitation in calcium, to now that's something we're thinking it's a strength on calcium for identification of calcium, assessment, risk stratification, and now even a randomized trial just focused on that. I've already shown this before, but of course, now that you can see calcium, you can understand your landing zones when you put the stent and whether you want to land it close to some segment with calcium or not. So my final key points to conclude with this is that, again, CT-guided calcium modification is an emerging concept. I think I've demonstrated that it's really good for triage and pre-procedural planning. You can get this tomorrow from any visualization software for the basic elements, cross-sections, length, Hounsfield units. But point number 3 is that they are these emerging concepts. 1, calcium distribution. 2, calcium density. You will probably hear about this more. And I think it's actually a very exciting moment for us in complex coronary interventions. Thank you so much.
Okay, on to the last presentation for this session. Thank you, CVI, for inviting me, and thank you, Manos, Subhash, everyone. Such a pleasure, and let me share with you some of my thoughts about CT-guided CTO PCI. These are my disclosures. I think every talk on CTO PCI often starts with the data from Progress CTO. This is, I think, pre-COVID now. I don't know if there is new data since then, but this is a group Dr. Brulakis leads, and it has taught us some very seminal findings in the CTO world, and I'm going to tell you why I'm showing this again. Number 1 is as the complexity goes up, the need for complex techniques go up. So remember that. Number 2, as the complexity goes up, radiation dose goes up, as well as contrast volume goes up. Number 3, as the complexity grows up, complications go up, especially perforations. So those things are very important. There is a lot of debate about the need for CTO PCI. There's a lot of doubters on that. So it is very important to do CTO PCI with the least amount of complications. It is very important. A lot of those patients are not coming with an MI. So that leads to this, in my involvement in the field of CTO with guidance, with CT guidance, because it tells me, allows me to pre-plan, and it also allows me to do intra-procedural planning. This is an example I'd like to start with. This is a 56-year-old male, active, used to play tennis regularly, but is getting limited over the last 6 months with exertional chest pain and shortness of breath. There was an attempt done at RCA CTO. It was unsuccessful. They used more than 400 ml of contrast, more than 5 grays of radiation. This is unacceptable. We cannot be subjecting a 56-year-old male to this kind of procedural event. And then he was actually referred to me for retrograde CTO PCI. But as we look at this, these are some of the images from outside. They were trying to open up this RCA. They just could not have the confidence where the artery is going. You just have no clue, 0 clue as to where this artery is going. Well, what we ended up doing is CTA. And in CTA, we learned very quickly that it's, of course, a very long CTO. It's not very calcified, some scattering of calcification. But the darn artery is very tortuous. It goes all around, and you can actually have this beautiful rendering done by our CT experts. I'm not a CT expert, but I rely on my great CT imagers to do this for me. And once this has been achieved, we also have developed this delayed phase for CTO work, where we actually do delayed imaging, and it's a dedicated CT protocol. Every time it's ordered, there's a 10-second delay, which allows, we believe, for better enhancement of the vessel characteristics and sometimes also better visualization of retrograde channels. Not only that, with the introduction of photon CT, as previous speakers have spoken, this field is going to advance tremendously. Once this data has been acquired, I bring this to the cath lab. And this is what it looks like under our CT integration PCI dashboard. It's very important for us to do that because we don't waste any time. As soon as a patient gets loaded, all the data is available for me to actually work on another monitor in the back of the room. And I can actually visualize the calcium, visualize the artery, and start working on this particular vessel. So as a patient gets loaded in the cath lab, there are 2 things we have to do. We have to obtain 2 orthogonal views of this coronary angiography, and then the image has to be registered based upon the coronary center lines and the ostia under fluoro. Those are two very critical steps to integrate CTA and CTO PCI work. So once that has been done, you can clearly see what happens. You get a green line. You know exactly where this artery runs. You actually also can see the side branches, and you know where not to go. So once that has been achieved, you start advancing your wire, and I did not even use any fancy technique. This is just a Pilot 200 in a Corsair. But I was very confident in where to go. All these angulations and tortuosity, I just kept on pushing through it, so to speak, because I knew that I'm not going anywhere else but staying within the artery, architecture of the artery. And then it was an easy PCI. My point is, this was done with very little amount of contrast, very little amount of radiation, just because of one fact only, which is CTA guidance. So why do CTO overlay and integration during CTO PCI? A lot of our previous speakers have spoken about it. It increases success rates, that goes without saying. It makes unsuccessful prior attempts successful and avoids bypass surgery. It reduces procedural time. It reduces need for retrograde attempt. As I said, it shows increases complications, reduces contrast, reduces radiation, as well as reduce perforation, and provides a roadmap like a GPS to navigate unseen coronary course with more and more confidence. This is our own internal project. We basically gathered 10 patients who were referred to us with unsuccessful CTO PCI. We collected all their data. We figured out how much calcification they have, the lesion length, the usual, and we also designated their JCTO score. The vast majority of the patients have JCTO score more than 2. So complex CTO PCI referrals. This is an example of one of those patients. This is a patient who has already undergone bypass surgery more than 20 years ago and now gets referred for this super long calcific CTO PCI. It's very daunting to look at this. You look at this image, it's like, oh my goodness, this is going to be tough case. But on the right, this patient had already gone through unsuccessful PCI, remember before. On the right, we acquired CTA, and you can clearly see there's a very straight vessel. There is no tortuosity. Yes, there is calcification, but it's a very straight vessel in spite of all his prior history. And with that, we were able to successfully fix that. And this is what the data from our preliminary gather shows. Number one, almost all the cases were done antegrade. The contrast volume we used was almost half of what we were using without the CT guidance or on the first attempt. The duration was shorter, fluoroscopy time was shorter, and so was the radiation dose. And obviously every case which was unsuccessful was made successful by the very fundamental fact that we used CT guidance to fix those arteries. And it's not just my little center showing you a small series of patients. This was a 400-patient study which got published a couple of years ago. And it did show something very similar, that when you do CTA guidance compared to just angiography, your success rates are significantly higher. Not only that, the more the complex the lesion, the more likely you're going to be more successful, and those results of event-free as well as less complications continue to persist over the next years. So just to kind of get your attention as to what are the advantages, there's been a lot of discussion about when to do CTA. But first and foremost, it is very good at defining the proximal stump. There's no doubt about that. It is better demonstrating the presence and/or degree of calcification, defining the CTO lesion length, especially with the delayed 10-second protocol. It can provide information about vessel morphology with CTO lesion, can characterize distal vessel beyond the CTO lesion, which often we cannot see. It will not miss any ostial CTOs and can be fused by fluoroscopy, as I've shown you there. But there are some disadvantages, obviously, of this protocol. We don't recommend that we do this on every one of our patients. I'll tell you in a second whom I do those on. But additional radiation and contrast exposure, additional testing and cost for the patient. They are obviously difficult distinguishing CTO from subtotal occlusions when it's very severely calcified vessels. And commonly used scores to evaluate difficulty of CTO PCI are modeled on coronary angiography derived CTO characteristics and not necessarily on CTA. I was just going to add to some of the comments, and then I'll let our esteemed panel give some extra pointers to us. When should we do CTA prior to CTO PCI? That's often a burning question, because as I started my topic, I really want to emphasize that CTO PCI should be kept safe. If you don't keep it safe, skepticism will keep on growing. There's already enough skepticism even about when to do CTA. So there are 4 categories that I can think of. One is obviously previous bypass surgery, as it has been alluded. Second is anyone who has had an unsuccessful CTO PCI. Please don't rush into that. Consider doing a CTA. It will teach you so many nuanced findings, which are very, very helpful. Third is where you do not have excellent visualization of the distal vessel because the vessel is tapered, diffusely diseased, or maybe not even as large as you thought originally, and there are no great collaterals to show. Please go ahead and do that. And fourth is the definition of calcification, as we just talked about. So thank you all very much for your attention. Thank you.
Janice, here for a second. I think we're over time, but I think we just have so many CTO expert operators here that I'll drop my 2 cents. I think we should do it all the time, but can we just go quickly, yes or no? Should we do CT routinely or only in failures? Maybe we just go down the row here, the row, okay?
Yeah, I think in our practice, it's still selected for some of the anatomical types you said. I think it is helpful if you're trying to figure out if it's an osteal right or they just didn't engage in some of those selected ones. But I think for the contrast volume in a lot of our patients with CKD, like the cost benefit isn't quite there in a lot of other non-post CABG patients for me. But again, I think it's how it fits into your workflow.
Wissam?
Starting tomorrow, I'll be using it for most of the CTOs and all the left main bifurcations. Take the guesswork out.
So?
About half the patients are CTOs. I do CTs, and of course, there's a lot of logistic issues and cost, and patients coming from outside, contrast volume, renal dysfunction. So, of course, those are the barriers that limit. In an ideal world, yes, most of the patients should have it, but if you don't live in an ideal world.
I think you will still have to be selective because of the difficulties that Kate outlined regarding the workflow we have. But surely we'll strongly consider it for a post-CABG patient to see all the anastomosis and the jumps like I mentioned before. If you have proximal cap ambiguity and you know that from a diagnostic there is only a very tortuous epicardial collateral, so you know that you cannot go retrograde, you really need to milk out all the information you can get from non-invasive imaging or any kind of imaging anyway. And so I would consider getting a CTA so it can show me where the proximal cap is, because it will show you where the vessel outline is. Sometimes it's absolutely not where you thought it would have been, and so that is a way to avoid complications. And then, in the cath lab, you can use IVUS guided puncture, bays, etc., to try to get into the vessel architecture, and at least maybe you're gonna be able to avoid going retrograde if it's high risk.
Arnold?
I agree with my predecessors. I think that at this point you have to be selective, but this case should be published, because if you have more evidence that this is safer for the patient, maybe you have to readdress that in the future.
Wonderful. So I think we're over time, so really thank everybody for a great session.